Good evening. I'm Dr. Linda Addonizio. I'm the director of the Program for Pediatric Cardiomyopathy, Heart Failure, and Transplantation here at the New York Presbyterian Morgan Stanley Children's Hospital at the Columbia University Irving Medical Center. Tonight, we welcome you to join the discussion about the cardiovascular effects on children of the novel coronavirus that we call COVID-19 for short. We will be discussing the impact of this virus on two of our vulnerable populations, children with pre-existing heart disease and heart failure, as well as children who have heart transplants and therefore are chronically immunosuppressed. Knowledge about COVID-19 is a rapidly changing landscape in medicine, and we hope to give you the up-to-date facts tonight. I am told we are joined by over 500 people from around the country, which is wonderful, and we welcome you all. A couple of housekeeping notes before I introduce our expert panel. Our intention is for this to be an interactive discussion, and we have allotted time for questions and answers. Please type in your questions as they occur to you, and we will attempt to answer as many as possible tonight. Following the broadcast, a summary document of key points will be sent to all participants. So don't worry. If we don't get to your questions tonight, we will attempt to answer them in the document. Now, it is my pleasure to introduce our distinguished panel from the Columbia campus. Dr. Eva Cheung, Assistant Professor of Pediatrics in Pediatric Cardiology and Critical Care Medicine. Eva will be focusing on the cardiac effects of acute COVID-19 infection, as well as touch on the multisystem inflammatory syndrome that can occur later. Dr. Lisa Saiman, Professor of Pediatrics in Infectious Disease and Hospital Epidemiologist here at the Children's Hospital. Lisa will update us on the continuing risks from COVID-19 and perhaps provide guidance for how we can keep ourselves and our children safe, particularly as we face the slow reintroduction of activities outside our homes. And then from my subdivision, two of my talented colleagues in heart failure and transplant, Dr. Marc Richmond, Associate Professor of Pediatrics, and Marc will talk about the effects of COVID-19 infection in children with heart failure. And Dr. Warren Zuckerman, Assistant Professor of Pediatrics. And Warren will be discussing how COVID-19 has affected our children with heart transplants. Finally, it is my distinct pleasure to introduce Dr. Max Gomez, the multi-Emmy award-winning broadcast journalist and medical correspondent for CBS. Max will be interviewing our panelists and in general, keeping us on our toes. So Max, do you want to get started?
I will, I do. Thank you, Dr. Addonizio. And welcome to all of our webinar viewers. I'm pleased to once again be moderating another in this ongoing series from New York Presbyterian Morgan Stanley Children's Hospital. We had been doing these in person, but since that's not possible right now, we're online, and I think that's probably a good thing because it gives us the opportunity to present important information, as Dr. Addonizio said, about this rapidly developing subject to a much wider audience. So you've heard that the introduction of our distinguished physicians from New York Presbyterian. We hope, again, you can use the, the chat function at the bottom of your Zoom screen there to type in some questions as we go along, and we'll be trying to get to those, particularly towards the end. So we've got an awful lot of things to cover here, so let's get started. And we sort of agreed ahead of time that we will dispense with the Dr. So-and-so and Dr. So-and-so. I think it's a lot easier and makes us all a little friendlier by saying, Eva, tell me a little bit about the cardiac and coronary effects here of COVID-19, particularly on children.
Sure. Thank you, Max, and thank you, Linda, for that very kind introduction. Welcome to all the webinar viewers. I'm happy to open this to give a little bit of an overview of how we've seen COVID affect this particularly vulnerable population of children with cardiac disease. I think there was, as COVID was surging in the New York City area, there was certainly, it had already affected different parts of the world where They were rare, but reports that children were less so seriously affected by the infection themselves, seeming that we were seeing adults being admitted on the order of thousands a day. But I think the worry from a physician standpoint as well as a parent standpoint is that this is a particularly vulnerable population. Children with cardiac disease or even really any kind of comorbidity, the real worry was how is this going to impact how those children would present and would they see a more serious illness. When March and April really hit New York City, and New York City was really surging with these cases, to give you an idea of a scope of the day, New York City alone was admitting on the order of thousands every day for inpatient adult respiratory failure. For the month of March into early April, which is really the peak of even our admissions at our institution for COVID infection, our colleagues, including Dr. Zachariah, recently published our children's experience with this surge during that time period in JAMA Peds. It was recently released in early June. And during that time, we admitted 50 patients, 50 children with COVID infection during that really heightened period of about 2 months in our city. But to bring it back to the focus of this particular webinar, when it comes to children with heart disease, of those 50 children, really only 9 of them got what we call serious infections, meaning that they landed in the ICU, they needed mechanical ventilation and intubation. But of those 50 patients, really only 4 of them had known preceding cardiac disease. Several of them had cardiomyopathy, which I'm going to leave for Marc to kind of talk about a little bit later. But some of them had just very kind of run-of-the-mill congenital heart disease in the form of ASDs, VSDs, and not particularly complex disease. I suppose that's kind of a breath of a sigh of relief a little bit, because there is a very large population of parents and physicians out there that certainly, are quite fearful about, this particularly vulnerable population, but that seems to have been our experience so far with at least active COVID infection. But then four weeks later, we saw this other phenomenon when it came to the multisystem inflammatory syndrome that really had a different kind of symptomatology. It affected a very different kind of patient population, and more concerningly, because it affected actually healthy children without prior comorbidities. And to date, in terms of our institution, we have not seen MIS-C affect children with congenital heart disease or cardiomyopathy, and really kind of really stuck with, again, children with really no prior comorbidities. Those children have had some cardiac effects in the sense of effects on myocardia, myocarditis, some coronary artery effects, which we can certainly talk about in detail a little bit later. But that really became its syndrome on its own. And again, we are thankfully several weeks, probably even more than weeks, a month and a half, into the presentation of the MIS-C particularly, and having seen about 60 patients in our ICU, in our hospital admitted with it, I think we can comfortably now characterize who this really affects. So that's kind of a summary of things, but I think we have a lot more to talk about in terms of heart disease and COVID in these children. You're muted, Max.
Boy, that was a rookie mistake. Quick follow-up on there, because you mentioned MIS-C, the inflammatory syndrome. How do those two things interact? You can see one without the other when it comes to the coronary effects?
Sure. So, MIS-C seems to really have been a kind of like a post-infection type of phenomenon. And I do not pretend, I am a simple intensivist, so I do not pretend to be able to give any kind of advanced science about kind of why it happened or why children had it. But we really saw it spike about 4 to 6 weeks after the very large spike of COVID infection in New York City. But the cardiac effects were really just truly a part of the syndrome in its whole. When children would come and present to us basically with like multi-system inflammation, part of that inflammation on about 15% of these kids did involve the heart in terms of cardiac dysfunction, seeing evidence of kind of maybe cardiac swelling or inflammation. And an even smaller subset of those patients, to date, we really only had about 2 that showed effects on their coronaries, dilation of their coronaries, kind of mild aneurysms, which I'm thankful to I don't want to fast forward and spoiler alert, but for the most part, they have resolved and gotten better. So I think it's a part of the spectrum of the disease.
But can you see coronary effects without having developed all of the characteristics of this inflammatory syndrome?
No, we really truly haven't seen that. I think we have done a lot of cardiac evaluation during this evolution of this syndrome, particularly out of just a lot of physician worry and parental worry, and a lot of parents who think maybe I had some symptoms, my child had some symptoms, I'm not sure, I don't know. So I think we've done more cardiac evaluations than probably were needed in terms of symptoms. And I'm thankful again to report that we have not found incidental cardiac findings in children that didn't have like a preceding, true full-blown symptoms of MIS-C and inflammation.
Got it. All right. Marc, let's talk about then the kids, it sounds like, who are most at risk here are those with some sort of underlying cardiac disease, coronary disease, heart disease, heart failure, et cetera. Tell me about what you've seen in terms of how COVID-19 has impacted that population, because I presume that's the population that you see very often.
Sure. As you alluded to, any child with heart failure, we tend to think of it being more risk for diseases that affect the respiratory system. The heart and lungs are intertwined, and typically we will see patients in heart failure have more severe respiratory symptoms for similar viruses such as RSV or flu, and be concerned about them contracting that. I do think while we have seen both COVID, the disease itself in our heart failure patients, as well as just asymptomatic positive patients who've been tested, whether because of some mild symptoms or more often than not because parents have been coming up positive with the disease. And we've not seen overly aggressive disease in these patients as compared to the rest of the children. So if you look at a lot of the adult literature, cardiovascular disease is a big risk factor for severe disease. And that does not seem to be the case in children. They seem to really follow a course relative to their age more so than their disease, thankfully. That being said, it very much can complicate things when they need more advanced treatments for their heart failure, because now on top of that, they have COVID and its respiratory and inflammatory consequences.
So that kind of begs the question then of why don't they seem to follow that course?
Yeah, and I think our children with heart failure are benefiting from the fact that they are children. And worldwide, we're seeing this be less severe in children than adults. Some recent data is coming out that may suggest that children have lower levels of the ACE2 receptor, which is the receptor that the SARS-CoV virus binds to gain entry into the cells. And that may be protective in most children, or at least mitigate the disease in many children. And I think they're continuing to benefit from that fact, which adults seem to really be susceptible to this.
Interesting. So Warren, I'm going to come back to you here to talk some more about heart and heart transplant patients here, but let me get to Lisa here and let's talk a little immunology. Tell me about what do you see in these children in terms of their antibodies, their protection, and so forth. Do they look like other children that you've seen, or do they look like adults at all in terms of their response to the COVID-19?
Yeah, it's a great question, and we don't know. The only group of children that we really consistently measured antibody responses in are the children that Eva was just describing with the MIS-C syndrome. And a lot of them no longer have positive PCRs for SARS-CoV-2, but are SARS-CoV-2 serology positive. And it would be a very important study, and people are starting to embark on looking at serologic prevalence in different age groups. And I think that's something that people might lean on when it comes to thinking about how to open schools or other environments. We'll get to the protective effect later. But unfortunately, you know, when we were at the height of the COVID story that Eva just talked about in March and April, we didn't have antibody testing available. So now we're going back and we're doing seroprevalence studies in healthcare providers and first responders, et cetera, but we haven't really had a systematic look at children yet.
Have you seen, or would you expect children to seroconvert and produce the same level of antibodies as we've seen in adults?
Yeah, again, there's some emerging literature that suggests that people that have milder disease have less robust antibody levels. So as we've all been saying, Marc talked about this too, if children are having milder disease, it's possible that they won't have the same antibody levels. But if they get re-exposed to the virus, they might be able to boost. So these are all of the questions that are just so top of our minds as we're thinking about how we're going to handle another wave of infections if that occurs, or when it occurs, as some people are starting to say, and also our response to vaccination.
We're going to come back to those topics because there's a lot to talk about there. So Warren, you deal with children with heart transplants, right?
Yes.
Tell me about that. You would think off the top of your head that these immunosuppressed kids would be A, more susceptible, and B, have more potential complications from the coronavirus. What's been your experience?
So I'm going to echo a little bit about what Marc said before, that we have to remember also that our patients do have the benefit of being kids, right? So I think it's a little bit about comparing how our patient population is doing to other pediatric, patient populations without the same comorbidities, and then also comparing them to how the adults are doing. The early reports out of China and Italy and other places that were affected before, we weren't actually hearing very much about solid organ transplant patients being any more affected than any other patients. The early reports out of China, I think, had only 2 heart transplant patients even affected, one of which was very mild, and the other which also survived. So those were reassuring. And certainly, when you look at our patient population on immunosuppression, generally speaking, when they're affected by viral illnesses, they're affected more than other kids their age, both in disease severity and disease length. And that is something that we have not seen with our patient population with COVID. We follow probably about, Linda could probably speak to an exact number, but we follow about 200 patients post-heart transplant. And we only have 8 that have any evidence of having COVID. And that doesn't represent all of the patients because we didn't test them all. But it hasn't overwhelmed our patients at all. Illustrating the lack of disease severity is actually the one patient who was hospitalized during the acute, the kind of COVID crisis that Eva was referring to before, is one of the patients that we follow with the most comorbidities. She's 14 years old. She was originally transplanted as sort of a toddler for dilated cardiomyopathy. And she, in October, actually had her 3rd heart transplant coupled with her first kidney transplant. She had a prolonged recovery, but she has been home for several months. She had signs and symptoms of viral illness, actually was checked out in an ER originally, had good oxygen saturations and a reassuring chest x-ray, and was sent home. She came back in a couple of days later. Her exposure was that her mother had a flu-like illness, actually did test positive for the flu, but then also later on tested positive for COVID. So when she came back to the emergency room a week after her original presentation, she did test positive for COVID. She had very mild findings on a chest x-ray and oxygen saturations in the low 90s. She was hospitalized for only 3 days, and oxygen was quickly weaned off, and she actually had a reassuring disease course. She was our one patient who was hospitalized in that acute COVID crisis. We have had patients who have tested positive that have all had exposure from very close contact with relatives who tested positive. They've all been managed as outpatients, actually.
So I'm going to ask you the same thing I asked Marc, but you can't answer the same way, saying because they're children. Why do you think that transplanted kids don't get as sick with COVID? I mean, transplanted kids, again, you would think would be so much more susceptible. They don't seem to be as sick as other kids, perhaps, and certainly not as adults. Is it just age?
So I think we'll take that in two parts. I think the first part is looking at the medications that our patients are on. They are immunosuppressed, but a lot of the acute illness from COVID does seem to be related to things like an immune response and a cytokine storm. And it's certainly possible that our patients who are on calcineurin inhibitors and have lower T cell counts and lower T cell functionality are actually protected against that acute disease process. That hasn't been proven, but it's something that we have sort of talked about as a transplant community, and it's certainly a possibility. The second thing to look at is I have to answer it a little bit with age, right? When you look at a publication that came actually out of our adult colleagues across the street, looking at their population of patients, that over 2/3 of the heart transplant patients in the publication that they put out had comorbidities such as diabetes and hypertension. Over 50% of them had coronary disease findings. These are comorbidities that don't exist in our patient population. So I think that when you compare pediatric solid organ transplant to adult solid organ transplant, they just don't have the same comorbidities that might be playing a role in the level of illness in those patients. The final thing I'll say is our patients are expert to begin with at social distancing, wearing masks, hand hygiene, things like that. Some of our patients are. A lot of them are, not all of them. But, these are things that I see, Linda smiling in the corner that she has talked about with our patients and forever. And our patients used to be the ones who wore a mask and, on a plane or even in a park and kind of felt like, they were ashamed of it. Now, all of a sudden, it's the norm. And I think our patients have been trained to social distance to begin with.
Good point. Good point. Eva, what about kids with other mild heart disease, underlying heart disease? Question asked, such as VSD, something of that nature. Any increased risk there?
No, and I saw that question pop up, and Max, and thanks for bringing that up, because I actually really think it's an important point to bring up. Even though we haven't seen hospitalized patients with even milder congenital heart disease like ASDs or VSDs, I think a really important point to make, and this may segue into a little bit about what Lisa may talk about later, is that we've certainly seen our share of COVID PCR positivity in even children with congenital heart disease, and this statement we've been saying a lot, who've been asymptomatic. And a lot of it when we are talking about now kind of getting out of the surge of COVID and now trying to get back to the care of these patients in our offices, in our ICUs, in surgery, in cath labs, there has been more than a handful of occasions, because we have adopted a universal testing policy of all these patients before they come into our hospital or come in for any procedure, not for visits, but for procedures. We have found incidental asymptomatic COVID in children with milder or even congenital heart disease. And that's just as equally important. Just because they're not affected symptomatically and they're not being hospitalized and they're not getting sick, for infection control, for exposure, for the families, and just so you know, that statistic is just as important, I believe. So yes, we're thankful that the children with milder congenital heart disease are not getting symptomatic and affected and sick and hospitalized, but we certainly are finding COVID infection in them.
Lisa, any correlation there?
It's such a great point. We talk about this all day long. And one of the things that I've wondered in the scenario that we're seeing now with these asymptomatic people being positive is whether or not this just represents what we're calling prolonged PCR positivity. And in point of fact, these children were infected back in April. And we know now that people can remain PCR positive for weeks to months. It's not viable virus. They're not going to transmit infection to others. But in the scenario that we're seeing, out of an abundance of caution, we have to consider them to be potentially infectious. So it's creating a lot of complexity, as you're all experiencing when you're trying to organize these children's procedures and caths. But that's what happens when you test with PCR. You're picking up potentially just a RNA fragment rather than truly viable virus.
Any way to distinguish between those viral fragments at this point? Any tests? I'm aware of some that are kind of in the pipeline waiting for some sort of approval from the FDA, but any way you can distinguish that? Because presumably knowing that they're no longer infectious would be a big deal.
Yeah, it's such a great question. Again, I've worked with all of the team on this. So we are using a couple of strategies. Bear with me because they're a little off the list of things we were talking about earlier. One is we are asking often to check serology. And if the child has antibodies, that really does suggest that they had been infected before, because it takes a while to develop an antibody response. And then the second thing that has proven useful, and you wouldn't, make clinical decisions, it's just other tools in our toolbox, is the actual, what we call the cycle threshold, that the PCR becomes positive. So when you run a PCR, you're, looking for the time in the process that you get a signal, yes, this is positive. The earlier the cycle, the higher the viral load. When your cycle threshold is very, very high, 30s, 40s, that has now been shown to not correlate with viable virus, but be much more likely to be what you just alluded to, a fragment of RNA rather than viable virus. So again, I'll emphasize, we don't use this to make clinical decisions, but it helps us with some of the things like isolation, duration of isolation, issues about whether or not we had an exposure or not. And again, we're just starting to learn how to use these tools a little more effectively.
By the way, I've been directing questions to individuals here, but if any of our panelists want to chime in and add anything to what someone else said, or contradict them or argue with them, that's okay. That's okay too. We want to make this as interactive as possible. Marc, you brought up before the ACE2 receptors in kids, and that the fact that they don't seem to express as much, and that might be somewhat protective. But what about other medications, say for hypertension, particularly in transplant patients, other medicines that may interact that may be problematic?
Yes, and I saw the question come up also about the ACE inhibitors that many, if not all, of our heart failure patients are on. So if you think back to March, just as the surge was really happening, particularly in Italy at the end of February, beginning of March, and as it was hitting New York, mid-March, there was a lot of coverage in the press, really initially, about ACE inhibitors and whether they actually might predispose people to infection because of the ACE2 receptor relationship with the SARS-CoV-2 virus. The short answer to that is no, it does not seem to put you at risk to be on an ACE inhibitor. And that's been proven now in a few different studies. Some of the larger studies have been questionable, but particularly out of the Lombardy region of Italy and out of New York City from our colleagues down at NYU, both put out large health system reports looking specifically at patients, adult patients, but adult patients with cardiovascular disease, and both came to the same conclusion that ACE inhibitors and angiotensin receptor blockers are not independent risk factors for more severe COVID-19 disease. The thing about that is that the reason that most patients are on it in the adult world, which is hypertension, is a risk factor. So they do hang together, but it really does not seem that it's the treatment of hypertension, more the presence of hypertension that's the risk. The question I saw come up says, could ACE inhibitors actually be protective? And to go back to kind of the initial concerns with the ACE inhibitors is when you're on one of these drugs, you tend to upregulate these receptors. So as we were all saying before, children tend to have lower levels of these receptors, which may be protective, but if you're on an inhibitor, you may your body raises the levels. So that's true, but the inhibitors, as they say, inhibit the activity of the receptors. And so now there's a thought that they may be somewhat protective, although again, in the adult population, that's not been proven either, just that they're not worsening the disease. So we are not making any changes to any of our patients' medications, ACE inhibitors, angiotensin receptor blockers. The other one that had come up pretty early in the course of COVID across the globe was ibuprofen, which we tend not to have our transplant patients use anyway because of the potential kidney effects. But that also did not pan out to be a true risk factor. So right now there are no medications that we are adjusting in any of our cardiology or heart failure patients because of concerns of worsening the disease.
Warren, any changes in terms of immunosuppression? It sounds like if it's not having an impact on the patients, you're not going to mess with their immunosuppression.
Yeah, we certainly haven't. But if you look at the adult populations, a lot of the time they are stopping medications, the anti-metabolite medications, such as mostly Cellcept and Imuran. There's nothing that has proven that to be either beneficial or harmful. We haven't made any changes in our patients. Echo what Marc said. We haven't seen any medications that we would stop. I'll answer one question. I saw a question about whether that we had any MIS-C in transplant patients. We haven't had any of our patients affected by MIS-C. I don't think there's been any transplant patients. Eva could probably speak to that as well. But I saw that question come up in the chat.
Okay. But before we get back to Eva, tell me about how the pandemic has impacted organ donation, because I imagine that's a pretty big issue for you.
It certainly has. I think, especially now, it's impacting different parts of the country at different times for sure. We definitely saw a period of time where we were getting less organ donor offers over the last couple of months. I think organ donation in a lot of places that are epicenters of the pandemic is kind of taking a backseat and not been the priority. I think that's probably one of the reasons why we were seeing less in terms of organ donor offers. It does seem to be picking up now. However, when you look at the data, there has been as many solid organ transplants in 2020 as there was in 2019. So I don't think it's been affected all that much. There certainly has been far less in terms of living-related donor kidney and liver transplants. Because a lot of the centers are putting elective surgeries on hold so that resources within their centers could be all funneled towards the care of COVID patients.
Is SARS-CoV-2 now an additional screen that you do in a potential donor?
Yeah, it is universally being done in all donors. I think actually multiple tests. We would not. I think that we wouldn't take a COVID positive donor, although there certainly could be circumstances where we would have to have an informed conversation with a family and talk about that. But it is universally being tested for in donors now. And I do believe that it is an almost absolute contraindication to acceptance of an organ.
Lisa, I'm saving a really good question for you here that will raise your hackles maybe a little bit, but let me ask Eva first, because we talked about this in our previous webinar. Are the coronary changes, this is one of the questions that you're seeing with COVID-19, similar, different than what you see in Kawasaki?
Right. So there was a lot of attention to the similarities of MIS-C syndrome to Kawasaki's disease. And much of it was because of whether or not we would see this future impact. Kawasaki's disease, for the audience, is a clinical syndrome of fever and certain clinical features that affects children. One of the biggest reasons to recognize it and treat it promptly is because it is known to be associated with effects on the heart, particularly coronary artery dilatation, as well as aneurysms, if it's not treated promptly and early enough. So there was certainly a lot of worry when there were some parallels with this syndrome to Kawasaki's when it first kind of emerged. I do think that, and several of our colleagues here at Columbia, I think would agree that this syndrome seems to be distinct from Kawasaki's disease in many features. It's affecting a different age range. Kawasaki's has a tendency to really peak with younger children. We have seen MIS-C across all age groups fairly equally. Probably the only age group that isn't terribly affected are infants. And with that, though, by certainly not fully understanding the syndrome and its true follow-up to date, we certainly employed a lot of the treatment of MIS-C extracted from what we know about Kawasaki's. So as I mentioned before, we've seen about 60 hospitalized patients in our hospital system with MIS-C. To date, we've only seen the suggestion of aneurysms in 2 of these patients, which were subsequently treated. And since we followed both of them up in the outpatient world, thankfully they have receded and they do not persist as aneurysms. So we're adopting a lot of the similarities. I think much research in terms of Dr. Gorelick and a lot of our other rheumatology and immunology colleagues is going to shed some more light on this in the future about why MIS-C involves the heart and how much we need to be worried about it. So again, similar, but probably its own distinct disease.
Wow, I had a different question for Lisa, but Eva raised this. Why does it affect the heart? Is that an immunologic question?
Oh, I mean, I think this, this is really fascinating, isn't it? I mean, I think that, for example, I can talk about the kidneys have ACE2 inhibitors. The placenta has ACE2 receptors. The placenta has ACE2 receptors, so we're worrying about in utero transmission, and the heart presumably does, right? So, but I don't understand the MIS-C syndrome. That is really, I mean, people are really gonna have to spend an enormous amount of time. And I keep wondering if, these are usually otherwise healthy children, but there may be something very unique about them, immunologically, that this just managed to unmask. They were in the wrong place at the wrong time, got a primary infection that they seemed to handle completely well. None of those children were hospitalized with primary COVID. But then their post-infectious phenomenon was completely off the charts. And that I think that this is why I'm so excited about what Josh Milner is doing, because they're really probing to see what the genetics of the genetic background of the children that have MIS-C is.
Got it. All right, let's talk vaccinations.
Do we
I won't ask you, well, yeah, I'll ask you. Are we gonna have a vaccine?
We're gonna have a vaccine. There's
in our lifetimes.
In our lifetimes, I can say, and I think I'm in good company. That's what Dr. Fauci says, so that's very, very promising. And the other thing that's so exciting is the speed, and the global cooperation that's occurring. The other thing that I think is really exciting is that multiple different kinds of platforms are being utilized, so that if one fails, which one will fail, more than one will fail, we'll have a lot of backup. And I heard a lecture by Francis Collins, who's the director of the NIH, saying that there's also an enormous commitment to, as things are going through phase 1, phase 2, and phase 3 trials, to have manufacturing happening to start to provide it the minute we know that it's approved, so we don't have to wait.
They're manufacturing at risk.
Manufacturing at risk, a lot of risk.
Right. But what about vaccination then in, say, the transplant patients or some of these or immunocompromised patients? Will it work? Could it be dangerous?
Yeah, those are the way I'm thinking of it now is, early studies are done in otherwise healthy individuals. First, you have to show it's safe, and then you want to show that you're raising an antibody, and that antibody is what we call neutralizing, meaning protective. And then you want to basically, you have to be in an environment where the people that have been vaccinated are seeing wild type coronavirus to see that it's truly protective. And that's what's called the efficacy of the vaccine. So the concerns that people would have would be immunocompromised people, will it be safe? And will it be effective? Will they develop an antibody response? And will it persist? And the other groups that are at risk are very young children. Will they make a good antibody response? Older adults, will they make a very good antibody response? There's going to have to be a lot of work done for subgroups. But I keep getting back to another very important strategy that we utilize for the immunocompromised hosts who, for example, can't receive live viral vaccines like measles, is what we call the cocooning strategy, where we make sure that everybody around them is vaccinated to protect them. And then I'm sure we'll get into other measures that can protect people like social distancing and masks later in the webinar. So I think that going into an immunocompromised population is going to have to wait as we're figuring out safety and efficacy in otherwise healthy people first.
Marc, what do you worry about when it comes to COVID-19 in kids, and particularly children, either with underlying heart disease or not? But what keeps you awake at night?
Yeah, it's what keeps me awake at night is not what we've been saying here, which is most of our patients that we've seen with this virus do well. It's the rare patient who doesn't. And they are infrequent, but they can have very, very severe disease. You know, I'll highlight one of our patients, you know, who was a teenager who had familial dilated cardiomyopathy, you know, doing well at home, who then had an admission for an acute on chronic heart failure, you know, exacerbation, you know, with cough and abdominal pain and nausea and vomiting and things that we would typically associate with just worsening heart failure. This was right around the time that the surge was starting in New York City, and I don't think we really appreciated the widespread community transmission of this disease. And so about 2 weeks into her hospitalization, her father tested positive for COVID. And within a few days, she developed fever and worsening of her status as well. And so she, of course, was also SARS-CoV-2 positive. So now we have a patient who has worsening heart failure and this disease, and we don't really know how she's going to progress from a respiratory standpoint and how much this is going to really impact her. And she did get quite sick. And how much of that was from her cardiomyopathy and how much of that was from the virus and how much was the interaction between the two was tough to know. But within about a week of her developing the fever from COVID, she actually decompensated with worsening heart failure, worsening respiratory distress, and had to be rescued using extracorporeal membranous oxygenation, or ECMO. Essentially be put on the heart-lung machine because now she had heart failure and respiratory failure from, you know, presumably the virus. You know, that's something that we sometimes do in our heart failure patients if they get very sick. But this really complicated things because the natural progression would be to then transition her to what's called a left ventricular assist device, essentially a pump to do the work of her heart because that's failing due to the cardiomyopathy. Well, in this case, we had lung disease also, so a heart pump alone wouldn't necessarily help her. And on top of that, our adult colleagues had seen patients who undergo cardiac surgery with recent COVID infections really do extremely poorly, mostly because of this inflammatory process, this cytokine storm that they see. So we had to support her on ECMO for about 3 weeks before we were all convinced that the COVID was no longer her main problem and that heart failure alone, you know, was what was keeping her sick. And then we were able to actually successfully do the surgery to put her on an LVAD or this heart pump. And the story wasn't over then. most of our patients, when they go on that pump, do really, really well. And she did in many ways, but then she started to develop a lot of signs of inflammation again. So this is now about 4 to 6 weeks out from the original COVID infection or SARS-CoV infection. And she developed fevers, and she developed all of the laboratory findings that now we're associating with MIS-C, but elevated inflammatory markers and the like. And she did require, despite getting all of the original treatments, including tocilizumab and remdesivir that we've all heard about in the news and in recent reports as potentially being beneficial, she still had this secondary inflammatory process and ended up needing pretty high dose steroids to make it go away and make her a transplant candidate. The good thing about this story is the happy ending, which was about 3 weeks after her LVAD implant, we were able to match her with a donor. By that point, we had successfully treated this inflammatory process that was happening, and she was able to undergo transplant successfully. So, you know, that's the patient that is always in the back of my mind. Where is that interaction between this new virus that we don't know a whole lot about, but we know can have really, really severe consequences, and our patients who are just on that edge of doing okay, but something like this can really tip them over. So that's what worries me. But, you know, knowing that we can treat this, and the more we learn about this virus, the appropriate treatments for it. I'm sure everyone's seen the news now about dexamethasone, just a different steroid, but really understanding that this virus is not just a respiratory virus, but an inflammatory disease is really helping us treat these patients who are the exceptions to what we're saying, which is children tend to do well with this. And I guess the tagline to that is except for when they don't.
I'm going to jump in there, Max. I'm sorry.
Go ahead, please.
There's certain parts of that story that keep me up at night in a slightly different way. And I think it's just prudent to say, especially since we have an audience that's from potentially from different parts of the country. And, you know, different parts of the country are seeing different rates of rise of COVID right now. And from, you know, and you know, Marc spoke very eloquently about kind of this patient and how vulnerable that patient was and how sick that patient could get. From a practitioner point of view, and from someone who's treating them, either as a cardiologist or an intensivist or those in the office, you know, our worries on our side, you know, especially from the hospital resource point of view, is that how we had to adjust and think about what we would normally do for a child like that because of COVID. You know, and we saw this in so many ways when it came to ventilators and intubation and the resources that came for adults, and what that meant for healthcare workers and exposure and how we had to adjust our practices. And I can tell you, again, to answer your question about what kept me up at night and similar practitioners like myself, is how can we make sure that we deliver optimized patient care, you know, in spite of COVID, in spite of, you know, all this barrier that was, you know, making sure that healthcare workers were protected, that the patient was best treated. There was a lot of adjustments that needed to happen along her course in many ways that Marc had to talk about, that I just think that many institutions across the country are going to have to be thoughtful about as they start to see cases rise around the country.
Especially because the treatment protocols are evolving almost daily, certainly weekly, as to what the latest thing is that might make a difference in these patients. To any of you, is there a way, are there any predictors of which patient is going to become this case that Marc was describing, the one that really goes downhill on you?
I think the silence is probably going to echo then what I'm going to say, which is not that we've seen. You know, we have seen some of our patients with really severe heart failure, ejection fraction of 10% from congenital heart disease or from other cardiomyopathies, you know, have a few days of fever, they test positive, and, you know, we're watching them every day. We're doing video visits with them every day. We're sending pulse oximeters to their house to make sure that they're not going to, you know, have hypoxia and need oxygen and admission, and do fine. We had a patient yesterday surprise us on antibody testing that he was positive after having 1 day of fever 2 weeks ago, and that was the only symptom. And again, a patient with very severe heart failure managed, in all the ways that we do that. So we've been both pleasantly surprised in some of our patients and how well they've done with documented infections. But I think, as Eva said, these patients keep us up at night worrying who's going to be the next one to show us severe disease.
Wow.
And we've done labs and cytokine panels and levels like that, and I don't think any of it is really borne out in terms of predictability. Eva might know some of the data on the cytokine levels and things like that. We've used tocilizumab and with high IL-6 levels, but I think it hasn't really borne out.
Wow. So Warren, I saw that you answered a couple of these questions just to make sure everybody else hears them. You said you wouldn't accept necessarily a donor that is, and I understand that there are no blanket statements here. You wouldn't necessarily accept a donor that is PCR positive, but antibody positive would be considered as long as they were PCR negative?
Yeah, if they were PCR negative, antibody positive, and didn't have any signs of active disease, it would definitely be something that would be considered. Like you said, there's no blanket statements, and one of the things that this has sort of proven to us is that it's unpredictable. We didn't expect to see a rash of Miss-C cases, and that happened. And I think it's hard to make any blanket statements, but if I was misleading before, I was referring to PCR positivity for unacceptability for a donor, if antibody positive would be considered.
Right. And I think Marc sort of didn't answer it directly, but a COVID-19 patient, once recovered, would be acceptable as a heart transplant recipient.
Yes, as long as there's no sign of active disease. We debated exactly when we could. Yeah, I mean, we did it. We're happy we did. But, the exact timing is tough. Do you just wait for the active disease to go away? Do you wait longer? We saw this second phase inflammatory response in this patient. But, the good thing is that the medications we use to immunosuppress, like steroids, seem to also benefit the patients with the inflammatory component. So I wouldn't hesitate to transplant any other patient who developed COVID once they're out of the acute respiratory phase.
Interesting. So Lisa, I believe it was you, no, maybe it was Warren, I apologize, who said that the transplant patients are already adept at social distancing, often wearing masks anyway. What do we do with those patients, or maybe any child, come September, when we've got to go back to school? And it's going to be tough for some of those, even though they may be good at social distancing, might be tough for them to practice that in school. Now, what do we do?
Yeah, this is on everybody's mind. And you're absolutely right. It's not just the children we've been talking about today. I'm sure the audience members themselves have children and they're wondering about what's going to happen. And it's certainly coming up for the summer months too. And it's coming up for people with children in daycare. And
Summer camp.
Yeah, summer camp, absolutely. And it's there's a lot of unknowns, obviously. I think that there's a tremendous amount of attention now being placed on the risk benefit of having kept schools closed. There's certainly been some enormous benefits in terms of being able to have the great outcome that, for example, New York had, but a lot of risks in keeping children at home, that, all the developmental things, educational things. I've been very, very struck by the enormous effort that the CDC and others have done with very, very thoughtful guidance. And one of the things that because I get this call at least twice a day now, what would you do if it was your child, et cetera. And I think it's super important to remind people that there are trusted sources of information like the CDC. I think it's really important to make sure that people are communicating with their own school districts, their own schools, to learn what is it going to look like in September? What are the plans put in place for classroom sizes, for the schedules? How are the teachers going to be acting? Where are the children going to be eating their meals? what is happening with the hallways. I mean, the amount of attention that it has to be placed on everything from bands to gym activities. It's beyond 10 webinars to have an adequate amount of time. I have become convinced that we have to do it. We have to open. I think that it has to be done incredibly slowly and carefully. I think that the themes for me that are emerging as paramount are making sure that the cohort that children are with is kept very small, so that if a child were to be ill or have an exposure, you would be able to do contact tracing to figure out who that child had exposed incredibly accurately and quickly. You need plans for quarantining the exposed children. You need to be able to work through mask use, which is not trivial, and where that's going to be acceptable and where it's not. And you know, it's beyond complex, but the thing I've been seeing, and because this is not the only group of people that are worrying about this. Oncologists are worrying about this. CF patients, cystic fibrosis patient providers are worrying about this. So this is just a generic sense of, you know, would these be the children that you would continue to homeschool for a longer amount of time, or would you be able to bring them back into the classroom? And, you know, I just don't have an easy answer.
Lisa, did we learn, or what did we learn from, was it the Denmark experience?
Sweden.
Sweden. Well, but no, I thought it was Denmark that opened the schools.
Oh, Denmark opened schools. Yes, I thought you meant the failed Swedish experiment.
No. From
yeah.
the opening the schools.
You know, I've been watching that news. You know, and I think that what you're alluding to, stop me if I'm wrong, Max, is that they started with very small classrooms. They started with more than one teacher in a classroom, so that children would be extremely well supervised. They actually marked the floor where the desks would be and emphasize that. A ton of what, you know, we would call good respiratory hygiene, good hand hygiene. Also meals that were delivered to the classroom, so that there was no like line in a cafeteria. I think we can learn a lot from those things. And there's a couple of really excellent guidances out there. I think, Linda, you had mentioned that we will send out responses, and I can send those links and we can embed them in the responses.
So it sounds like bottom line there is that parents need to be very involved with particularly with these children, with any of the children going back, but particularly with these children. Ask those hard questions and don't just trust the school system to get it right.
Yeah, I would really agree with that. And I think, you know, emphasizing that attending town halls when they exist, asking for written information, it's almost as complicated for me as it was running a hospital, you know, and trying to keep us functioning during all of this. It's a lot. And I also think there has to be tolerance for some failed parts of it, you know, like there may be a 2 steps forward and 1 step back, and somebody said, I heard in our thing today, that in pediatrics and in children, there's only the numerator. The rate doesn't matter. It's just that one child that you know, got sick while they were at school that's going to make everybody very, very worried.
Yeah, particularly for the parents.
For all of us, right?
Yeah.
And I'll speak to that too, because a couple of the questions are addressing specifically immunocompromised patients. You know, everything that we've talked about has been very reassuring in terms of our immunocompromised patients, but it's unpredictable. And what Lisa just said is true, right? If the numerator is 1, and that's the, you know, I think for everybody who asked those questions, we need to do what Lisa said, but I think everybody needs to do that anyway. But, you know, if you have immunocompromised children or patients, I think you do need to be extra vigilant, but it is certainly true that everything that we've seen up until this point has been reassuring about the specific effects of COVID in our patient population.
Oh, that's good.
Max, you know, may I have the talking bear one more second here? The other thing that I think is out there that we have to address is that when decisions were made to close schools, which was unbelievably difficult, we already knew from the China experience that children were not having the same impact as we've been talking about this whole evening, but that the children were coming back into households and they were potentially exposing at-risk individuals. And I think that that's just something that we're going to have to really pay attention to. So all the risk factors that we know about now in adults, like obesity and underlying diseases and age, those children are interacting with those people. And especially in a community like we work in up here in Washington Heights, where we have these multi-generation families
Living together.
It's going to be really complicated. So it's not, I do, think of myself as a public health person. It's all of these levels that school openings affect.
Yeah. So there will be bumps along the road, but hopefully that's where we learn. Now, before I turn it back, because I see that we're sort of running a little bit out of time here, before I give it back to Linda to wrap up, Eva, you're going to go first because you know that I asked this the last time. I asked our panelists for a very brief, those being the operative words, pearl of wisdom, a little take-home message that you want our webinar viewers to remember from what you said and what you've observed in your clinical experience here. And Eva, you get to go first.
Thank you, Max. I don't think I got to go first last time, so I appreciate the promotion. So if there's a pearl of wisdom, I think that as much as we want to give the reassuring experience that children with cardiac disease, transplant, cardiomyopathy, hopefully you've heard that we've given some positive stories about, the effects of COVID on them. But regardless of that, I think that it was in no part, I believe that things like social distancing, testing, things of that kind of vigilance that also contribute to it. And that has to kind of maintain forward, as much as we are giving the good news that children are coming out of this, fairly okay. And it's not, and I don't think we got to talk a lot about it on this webinar, but we did with the last. It's also not because of lack of treatment. These kids did get hospitalized. These kids did, require medical attention. So, I think there are lessons learned from our New York City experience, what these kids look like, what the symptoms of MIS-C are, what could affect children with heart disease. And that vigilance has to remain because this is not gone, it's not gone away. And the rest of the country is going to see this as well. And so vigilance, social distancing, testing, I think all part of that is going to be really important to keep our children healthy.
Warren, you want to try?
My pearl would be that something good can come out of everything. And out of this pandemic, I think, something Eva mentioned before is that we've learned to do things a lot differently in the hospital, and we're learning to do telemedicine, which is something we didn't really touch on tonight. And we're learning to educate fellows and residents and do all these things over Zoom that we weren't really doing hardly at all before. So I do think that some good can come of even this, and that's what that would be my pearl.
That's good. I like that. Lisa, how about you?
Social distancing and masks work. Please don't relax your vigilance, even in the beautiful warm weather, even as we move into phase 3, phase 4, we have to continue to do those measures.
Real pearl, thank you. Mark, last but not least.
Yeah, I think I have two pearls. I think the first one is to not believe what you read right away. The ACE inhibitors being a great example of that everybody's learning about this virus at the same time. And initial impressions may not be what ends up being the reality. And I think the second is, we can, particularly when we're talking about children and our population of children that we care for, we can be reassuring, but also vigilant. And to Warren's point of telemedicine taking off during this crisis, we were and still do follow new diagnosis of COVID in our patient population very closely, and we're able to do that through telehealth. And to be honest, something we wouldn't have been able to do without telehealth. So I think we can be reassuring, but still be vigilant at the same time, looking out for that one child or to children who will keep us up at night.
Excellent. Thank you all. I actually took away some reassurance from what you said here when it comes to children, transplant patients, immunocompromised, and so forth. But I think that vigilance and being involved is going to be very important. Linda, would you like to wrap us up, please?
Thank you, Max. Well, we hope you've enjoyed our program tonight and learned a bit more about how COVID-19 can affect some of our most vulnerable children in our pediatric population. Remember, we're going to try and answer all the questions that we didn't get to tonight because of time, and that'll be sent to all the participants. I would like to thank our expert panelists for making this evening interesting, and I think a success, and for all you do every day to care for our children. I would also like to thank New York Presbyterian Hospital and Columbia University for sponsoring this webinar and the multiple people whose efforts made this possible, believe me, in record time. And a very special thank you to Dr. Max Gomez for your expertise and your skills in directing our discussions tonight. So from everyone here at the Columbia campus, thank you all for attending. Stay safe and good night.
Wear a mask.
Wear a mask.
Please.
Thank
Good
you
night.
all.
Good night, guys.